Good afternoon, everyone. Thank you for your patience as we got started with our speakers and got everyone situated. But my name is Jenny Bogard, and I am the Executive Director here at the National Hypertension Control Roundtable. And we are delighted to have this fireside chat focusing on lifestyle medicine and health equity. Our very own co-chair, Dr. Andrew Freeman, who is the Director of Clinical Cardiology and Operations, and the Director of CVD Prevention and Wellness and the Associate Professor of Medicine at National Jewish Health, is going to moderate today's discussion. Andrew, I'll pass it over to you to introduce our amazing speakers.
Well, excellent. It's such a pleasure to be here. I love talking about hypertension control, and we're going to spend some time today applying how lifestyle really makes a difference here. And I'm joined by my esteemed colleagues, Dr. Kim Williams and Dr. Alison Bailey, and I'm going to read all this great stuff about them. So let me pull it up so you can hear just how amazing they are and not just take my word for it. So Dr. Alison Bailey is the Chief of Cardiology for Centennial Heart at Park Ridge in Chattanooga, Tennessee, and Physician Director of the Cardiovascular Disease for HCA Healthcare. And her clinical practice focuses on prevention of cardiovascular disease, women's cardiovascular care, and the diagnosis and treatment of heart failure. And she also serves as the president of the board for the Chattanooga chapter of the AHA. She's editor-in-chief for the American College of Cardiology's Extended Learning, which is called Axel editorial board, and a board member and secretary for the American Society of Preventive Cardiology. And Dr. Kim Williams is the endowed professor of health equity and chairman of the Department of Medicine at the University of Louisville. He originates from the South Side of Chicago, transitioned from the inner city Chicago public schools to the College of the University of Chicago, where he majored in biology and earned 4 maroon varsity tennis letters, playing #1 singles for his last 3 years, and subsequently taught and played tennis professionally, then trained at UC Pritzker School of Medicine, internal medicine at Emory, and back to UC for cardiology, clinical pharmacology, nuclear medicine. He's board certified in everything: internal medicine, cardiovascular diseases, nuclear medicine, nuclear cardiology, and cardiovascular CT. And then he has served as the past president of the American College of Cardiology and the American Society of Nuclear Cardiology, and as chairman of the board of the Association of Black Cardiologists, or ABC. His career is focused on advocacy for national nutrition education, eradication of national and international healthcare disparities, improved healthcare access, overall health system reform, sustainable healthcare and financing, and increased access to advanced cardiac imaging. He's also served as a delegate to the AMA and a consultant to the FDA and CMS. And many more accolades. I could probably spend the whole hour talking about that, but I'd rather talk about lifestyle medicine and how it matters for hypertension. So welcome, Kim and Alison. Thanks for being here today. So first, I always like to, when we talk about hypertension, it's just remind everybody who's listening just how big of a problem it is. And I'm curious what you guys are seeing in your neck of the woods. I'm in Denver, and Alison in Tennessee, and Kim down in Kentucky. But how big of a problem are we dealing with, and why does it matter so much?
Well, I'll take the easy one here. It is such an important problem. About half of Americans will have hypertension in their lifetime. So 1 in 2 of us will deal with that. The likelihood of having it goes up as we age. And if you live in the South, like I do, that rate is considerably higher. It's really, really important because it increases the risk of developing stroke, coronary artery disease, heart failure, sort of all the things none of us want as we age healthfully in this world.
So I would just add to that, as we all know, there's a huge degree of ethnic disparities here. I know we weren't going to do slides, we just happened to bring one up, so I'll just read it to you. So the whole idea is, once you're 65 or over, 65% of Americans above 60 have hypertension. But if you take all ages, obviously it's going to drop down lower. But yet the one that sticks out is the non-Hispanic Black population, 42% hypertension compared to the next highest, which is non-Hispanic white at 28%. Those outliers by race have to do with so many factors that have been, there's a wonderful JACC article that talks about the importance of social determinants of health, physical environment, social support, education, racism and discrimination, and access to quality health care. all of them contributing to the hypertension crisis that we have that's resulting in more heart failure, more strokes, and more, renal failure. We are 12% of the population in the United States and 35% of the dialysis patients. So I would love to, talk more. I've got some surprising stuff, but I know you want to ask other questions, and I'll get back to, all that list of underlying things. It's missing a couple that are really important.
Well, I think these are super important topics. And the stats that I like to share, of course, is that for every 20 points, roughly, people go above 120, the risk for dying like doubles. So it's an exponential problem. And I know I'm rounding a little bit, but it's one of those stats that I think we as clinicians really need to share with our patients, because somebody comes in and their blood pressure is 140 and it's been that way for 10 years and everyone says you're just fine. It really may not be. And I don't know about you, but walking around with double the risk of dying sounds less than ideal.
Right.
So let's jump in a little bit more and explore what you do in those particular situations. So one of the things that we face all the time in our clinical practice is you inherit a patient, they get referred to you for whatever, let's say atrial fibrillation or mitral regurgitation. And then you open their chart up and you do see that their blood pressure has been high for years, decades, many decades. What do you do? How do you manage it? And of course, we all know we can give guideline-directed medical therapy, but what else can we do for people that has a lasting impact? And maybe we'll jump back to Alison first.
I think that's great. And I think we all encounter this clinical inertia after you've seen someone for a while. So I try not to, first of all, ever blame or judge the person before me. But the second thing I'd talk to the patient about is, let's talk about your blood pressure. It's high here. Are you checking your blood pressure at home? I think that's incredibly important because we do see some white coat hypertension in the office. And so we talked to them about appropriate way to measure blood pressure. You need to be sitting, you need to be relaxed, all the things. And then getting a blood pressure cuff that's accurate, and I make sure everyone knows about validatebp.org, which most people on this call may know about, but it's sort of validated blood pressure cuffs that can be bought commercially. And then I tell them to make sure that they get a good blood pressure cuff, to keep a log. Blood pressure is something that kills us over the next 10, 20, 30 years, not the next 30 days. And so we've got time to get the blood pressure down, but we want to make sure that we're all on the same page about what our goal is. And our goal is less than 130/80 for sure with medications, and optimally less than 120/80. And then we go through why that's important. And I use exactly the same quote as Andrew just said, that 20 systolic or 10 diastolic roughly doubles our risk of cardiovascular or all-cause mortality. So I start with that.
All right. And so, Kim, how do you build on that? What do you tell your patients next? So you put them on a medicine. What else can you do?
So the first thing we do is talk about the guidelines. And I'm so glad that Alison mentioned the fact that we have been talking about this since the 2017 hypertension guidelines. And I always joke that I never get upset when doctors don't follow guidelines unless I wrote them. So this one was you just feel largely ignored. The number of people who actually come in saying, I've had hypertension, I'm taking these pills, and here are my blood pressures. I've had one since I've gotten to Louisville that actually brought blood pressures without being asked. It's such an important thing. And there's discrete literature that talks about the fact that the event rate is lower if you do home blood pressures. But there's one other thing that people may not have read every line of that guideline, but it talked about masked hypertension, which is a very sensitive issue. Office hypertension is where your blood pressure is higher than it is at home. It is important. That is, the 5-year incidence of sustained hypertension is about 30% if you follow people who have office hypertension but not blood pressure at home. But masked hypertension, you have people living in a difficult neighborhood or a difficult situation. They're at home. Sometimes they're alone. Sometimes they're not alone. Sometimes it's domestic violence or elder abuse. And their blood pressure, after they've been waiting for me to get in the room, calm, safe, it could be, and this is in our guideline, 30 millimeters lower in the office than it is at home. We need to know that. And so both of these occur at about 13% of our patients have masked hypertension, depending on your population, obviously. And so we need to just double down on that. Now I want to answer your question, okay, which is, what do we do? The first thing in that guideline is lifestyle. And yeah, you can hang out, obviously, if someone's getting to 150, 160, where you know that the 10-week risk is starting of a stroke is actually going up. you do try to intervene with medications. But the first thing we do is lifestyle. We're talking about sodium reduction, as much plant-based nutrition as you can do, backing off of the alcohol. You know, that's one regret we have as a committee that we've talked about, because we kind of talk to each other still after 7 years. That if we could do it over, we would remove that 2 drinks per day for males and 1 drink per day for women. There's 0. There's 0 is good for you. It's bad for your liver, bad for your brain, bad for your heart, and bad for your blood pressure. We shouldn't do it at all. So we start with lifestyle. Are you getting the exercise? 150 minutes is in the guideline, but we all know that we prefer 300 minutes per week, and trying to lose weight. If we implement, and I mentioned the sodium, there's a number in the guidelines, it's 1,800 milligrams that you'd like to be below. And there's also potassium that you'd like to be above 3,500 milligrams. And that's our whole lifestyle section. And if we could get people to do that, we wouldn't need as much in terms of drugs.
Well, and another point just to underscore that, of course, is sleep and sleep quality, right? So undertreated sleep apnea. I mean, if you have a patient who has refractory hypertension or has been hypertensive for 10 years, it is so darn easy these days to get a home sleep study. They have all these little watch devices or whatever, and many times that helps. But I think you're right, Kim, that the potassium part is often underestimated, and people think they can just take a potassium supplement. But really what we're talking about is potassium in the form of fruits and vegetables, right? Things that you can get at your grocery store. So then that brings us to places that many of us have either trained, we live in, we work in, where safe exercise and food deserts are a major issue. And as you know, Alison, in the South, you could argue the entire South might be a food desert in parts, but we'll leave that for a different day. But Kim, I'm curious, you've had lots of experience in various parts of Chicago, and now where you are in Louisville, where I'm sure these are major issues. And how do you deal with them in everyday practice?
Yeah, so I like the big picture. When we were having that nutrition, health, and hunger, we're all making recommendations to the White House. What I try to get across is that the food deserts it's just misspelled. It's actually food desserts. As that mom and pop grocery store on the corner is not in the healthcare business. They're in the keep mom and pop open business. And that means that they are going to sell what people buy. And if people are buying bad food, that's on us. And so what the White House did commit to was community education. One of those that is high on the list, and I know FDA has wanted, or Rob Califf, one of our colleagues at ACC, has wanted to move the nutrition stuff to the front, so people know that they're getting saturated fat and cholesterol and high amount of sodium right up front. What I was pushing for was red, green, and yellow labels in the grocery stores, so people know. That's actually been done in Austria, France, and Australia to limited degrees, because people don't like it. If you're selling something that's red, like bacon, you're not too happy with the sales, because it changes the sales. So we need to do more in terms of community education, getting people to know, and then support the mom and pop grocery store buying fruits and vegetables to sell. And that's our job. And we just, obviously that's the big picture. In this situation where we're in now, where we're not there yet, we do try to get people to do exercise indoors. I don't want to ignore that one, because there are some places where there's gang violence, and not maybe as bad as the south side of Chicago, but there's still. And what we try to do is get people to use their stairwell. I do that a lot, and it's a good indicator for how well you're doing. And when that stairwell becomes really difficult, hopefully they'll report it, and we can get ahead of any pathophysiology that's going on. But other than that, we try to get people to recognize that beans, grains, nuts, and seeds are actually, you could buy them in bulk, and they're really inexpensive when you do it that way. And the fruits and vegetables, a lot of them, maybe not your lettuce, but a lot of things can actually be frozen, so you're not worried about spoilage.
Yeah, and I think those are great points. When I was in training, I was in North Philadelphia, and I would encourage patients to take the bus to the suburbs to stop at all these fancy grocery stores and pick up the beans, the frozen veggies, the rice, the things that they couldn't readily get. And some people took me up on it, and the results were always extraordinary when they did, because you can imagine that cheesesteaks are not a diet to live on. So, Alison, how about for you? What do you do? Because the Southern diet is a real thing, and it's held really close. It's a cultural thing. People think you're attacking their inner persona when you tell them to change their diet. So what do you do?
Yeah, no, I think that's a great point. And I'm going to add a comment to what Kim just said first before I answer that question. But I think if you're working in some of these communities that have food deserts, that we have to work together to try to make it better. So we're in a food desert where I'm at. We've partnered with one of the sustainable food institutes in town. And so there's a grocery store that's in the basement of one of the churches that has locally produced fruits and vegetables in season. They have beans, they have a peanut grinder. It's open 4 days a week. They take SNAP credits. And so I think you have to try to improve things where you are, as well as talking about the bigger picture of sort of the world. The Southern diet, people live and die by the Southern diet. They absolutely love their Southern cooked vegetables. And so we actually teach a cooking class in our neighborhood. It's free for anybody that wants to come. It's called Food RX. And we talk all about plant-based nutrition, but we put a Southern spill on it. So we say, you may love this, which is collards with, fat back in it, but let's make this instead. And we give some good alternatives to that. It's been super successful. It's, our first class, I think we had 4 people in. We have 55 people a class now, and it goes over 8 sessions. And patients really love it. Community workers love it. Our employees from the hospital like it. We teach plant-based cooking in our cardiac rehab programs as well. So that's kind of hitting the population of people that's already had an event, the highest group of people. But I think that meeting people where they are is the most important thing we can do with diet. And so my words to them are, I live a plant-based diet because I believe that is the diet that's been associated with healthy longevity. And that's what I want. I want to go out kicking and screaming at 95. And I'm going to share with you why I think this is good for you. And if you do it 1 day a week or a half a day a week or try to incorporate it into a few meals a week, it makes a big difference. But the things we know is that these type of diets are lower in sodium in a natural way. They're high in potassium by design. They're low in saturated fat, and they make you feel amazing. And so I want you to come into this with an open mind and think about it. And I think we have, pretty good successes. Not everybody's willing to change right off the bat, but limited successes.
Well, yeah. And I think when people really think about it, one of the things I say is, look, if you get together for holidays, Thanksgiving, Christmas, Hanukkah, New Year's, whatever it is, and we get together, we cherish the life, our family, our friends, and then we poison each other, right? Like people really sort of resonate with this. And I think it's an important way of trying to relate to people. But I think the magic is actually giving people a meal that tastes good. And the truth is, we all know that you could take the EKG the patient got just done in their office and dip it in a curry sauce and it'd be delicious. So getting people to see that things taste good that they wouldn't normally try is really powerful. And I think the cooking classes we've done as well, in our intensive cardiac rehab, we've done this. And it's a really powerful approach for people to say, oh, this is an aha moment. And then even better, all of us have been involved in hospital food initiatives, right? Wouldn't it be amazing if all of the places we worked and we touched and we were affiliated with saw themselves as true places of healing and actually served healthy foods? So I'm curious, Kim, what have you done in Louisville and maybe even before that in Chicago to get your hospital to kind of see the light?
So I have to talk about the before because Chairman of Medicine, I like to say the only good thing about the 18-hour work days is that unless it's the president, the provost, or the dean, I get to choose the 18. But it's still 18 hours. So it's on my radar. I've been focusing on the West End. That's the poorer area, the area with more poverty, more African-American illness. We're trying to do access. So just working on so many things. And hospital food is just now coming to the place where I'm putting together a committee to try and do some initiatives to reproduce what we've done, what we were successful at Rush. So a shameless plug for the International Journal of Disease Reversal and Prevention. We have 3 different articles. We got the Monica Agarwal and the Emily Lambert from Rush. Dr. Agarwal is from Florida, and Rob Osfeld from Montefiore, all talking about how to change hospital food. And those articles are very insightful, and they play off of each other in terms of the learning. The obstructions are, the meal trays are going to be too expensive. We can't afford another 2 cents. It's not in our budget. And so with the help of Dr. Barnard, who was at PCRM in DC, finding the vendors who actually lower the price. And that's what changed things at Rush. I mean, there were other things. There was the whole idea of Press Ganey is going to be bad if you're giving people vegan options. Turns out that's not true. People feel like, oh, they actually care about me. And, you know, I would always joke with the patient, you know, you had a stent. It's because you ate things that blocked up your arteries, cholesterol and fat. And I'm recommending a plant-based diet. And if you choose to do it, I'll be happy. And if you choose not to do it, we'll make money. But back to the matter, that was what I used to say. Nowadays, after being in Kentucky for a while, now I say we'll make money for a short period of time. So it's because it really is devastating being more exposed to the Southern diet than I was in Chicago.
What about for you, Alison?
Yeah, no, same thing. I've had, I would say, limited success with getting sustainable change in the hospital systems. Now, we do have a plant-based menu that's an option, but people can still get the bad food. So we're going to continue to work through better ways of making the entire menu healthy. But, it doesn't stop me from telling patients about healthy food resources and places to get food. And, the question everybody has is cost. And, we sort of have debunked that over and over and over again. Beans are a lot cheaper than any animal product you're going to buy for protein, and a much better source because they give you fiber. So they reduce all of the risk of colon cancer and all the other things that go along with that. And then, really talking to them about ways that they can introduce this to their family. I think even if someone's not willing to improve their health for themselves, you start talking about doing it for the people you love, you sometimes can get a lot more buy-in from that standpoint. And I'm going to go back to one other thing Kim said about exercise. So when I walk into my heart failure clinic and my patients are in there and they tell me, Doc, I can't walk across the floor without getting short of breath, we go through the whole list of things. We're going to treat you appropriately for your heart failure, but part of this is on you. You've got to start exercising. And for those patients, if I say 300 minutes, I've already lost them. So I start, and we all know this, but I make sure I start with them, 1 minute of exercise a day is better than 0 minutes of exercise a day. And if you can only walk around your kitchen, that's okay. Do it 10 times a day. And our goal is going to be to get up to a minimum of 150 minutes or thereabouts a week. But we want you doing some form of exercise. And I think we have to put it into these little bite-sized chunks when we're starting off with people who aren't tennis lettermen. Kim, I didn't even know that about you. That's amazing.
Yeah, these are amazing points. And I think that we probably don't drive these home enough. I mean, the thing that I often will reference with my patients is what I call the American curse, which most people can resonate with, right? You work hard your whole life, you save your money, you get ready to retire, and then you don't just die, but you suffer with heart attacks, strokes, dementia, erectile dysfunction, all these terrible vascular diseases, diabetes and loss of vision and all these things that many of them are truly avoidable. And I want to point out that one of the things that we've been saying, but I'll just say flat out, is it's really the combination of healthy lifestyles that go together better, right? So it's eating well, it's exercising more, it's stressing less, which us doctors are not so great at. It's connecting with others and having strong social support. And of course, good quality sleep for about 7 to 10 hours a night. And I think very, very few Americans can get all of those. And the ones that do, the results are extraordinary. And Kim, you've definitely shared stories of patients who've called you up over the years, and they're about to pass out, and you tell them, congratulations, you can get off their meds. But I think those kind of stories are really powerful for patients to see. And then one of the things that I think we should probably touch on is a little bit about how we kind of hook our patients into making these changes. For me, it's usually a form of motivational interviewing, where somebody comes in and they're talking about their kids or their grandkids or whatever it is. And I really try to, grab onto it and say, it sounds like you can't really run around with your grandkids. What if we could change that? Or some other whatever motivating factor. And I'm curious, what kind of techniques you guys use in your patient populations? And then particularly when somebody says to me, well, I can't do that. I don't have a safe place to live. I don't have a kitchen I can use. I don't have access to fresh fruit or vegetables. It's not safe for me to walk outside. What do you guys do? How do you solve some of these problems for some of these patients?
Well, I use Walmart. Everybody knows where a Walmart is. And so I'll talk to my patients, where I live, there's a large rural population as well as sort of the city population. And there aren't necessarily a gym at every corner and people have to drive longer distances, but there's almost always a Walmart or a grocery store. And so I recommend they go there and walk around the store. Just don't buy everything on the inside aisles that where the processed food usually lives, but try to do it other places. Or schools are also a good option. Most schools have either outdoor tracks or some availability inside that they will allow community members to come to. And then, silver sneakers and programs like that, I think a lot of our patients aren't familiar with, but a lot of insurers have a program called Silver Sneakers where you can join gyms for free, or you don't have to pay a membership, but it's part of your insurance program. So I make sure I point that out. And then for things like Kim said, taking the stairs when possible. And I joke, why are stairwells like the ugliest place in the entire building, right? Or you feel like you're going to get mugged in most stairwells. It's gray, it's not painted. And so I think I saw this program, we haven't done it here, but I saw a program where they painted the stairwells in these schools and hospitals in really great motifs. And it really encouraged the number of people who came in and walked. So I thought that was really interesting. And we're working on a project like that.
Well, that's fantastic. We do have some resources here in Louisville. One of our, if you want to call them competitors, I don't call them competitors. I guess I haven't been here long enough. This big hospital system called Norton. They actually built on the West End on Muhammad Ali Boulevard, if anybody's listening from Louisville, a large health and wellness facility that actually is a huge track and a huge gym, and people can go there and use it at low cost, no cost, and they're actually do a lot of events there. We do our screening events are, helping everyone address risk today. That spells heart, by the way, where we do the finger stick and the ASCVD risk calculator, lipid panel and blood pressure, and tell people what their 10-year risk. So we go there at least once a year and do that. And a lot of traction around that track.
No, it's fantastic. And here in Denver, I've been doing a walk with a doc program for the last 14 years. And, the nice thing is you pick a park that's on a bus route, so anybody can get to it relatively inexpensively or for free. And then we walk with our patients. We provide a healthy breakfast with fruit and coffee if people want, black or with soy milk, which is great. And we go for a good walk. And it's been a really powerful way to touch people because they get to see you, in your gym clothes on a weekend without the copays and all the other stuff that goes on with office practice. So I think there's a lot of great ways of doing this. So, that brings me to some of the sort of next things to think about. So we talked a lot about nutrition. We talked a lot about exercise. But are you guys incorporating some of the other facets of lifestyle medicine? So stress, sleep, and social support into your day-to-day. And let me just point out to the listeners, the medical word for high blood pressure, of course, is hypertension or too much tension. The very word we use, disease, dis-ease, or lack of ease, is a super common way of thinking about how much patients are experiencing. And then, of course, all it takes these days is to flip on the television and the world is on fire and the political scene is scary and everyone doesn't know what to do. And it's a stressful world we live in. So I'm curious, what are you guys doing, if anything, to help your patients get through these challenging times?
So can I start with that one? I want to just talk about the idea that stress is important. We should have known this years ago from that old rabbit experiment where the ones who were they were all being fed animal products, and nobody should be eating animal products because you develop heart disease, even in a rabbit model. And so that was the whole point. So you could study atherosclerosis. But, and Dean Ornish talks about this all the time, but the ones who were on the bottom row who were being petted, it was ruined. They didn't develop coronary disease like the upper rows where they weren't being petted. But if you translate that to human behavior, there's a massive literature on, any relaxation technique. We're talking scripture reading and prayer and Tai Chi and transcendental meditation and mindfulness, which was always part of, I mentioned Dean Ornish, always part of that program that you all have. This is so important that it's a major, major issue. And so I talk to my coronary disease patients about the stress in their lives. And we talk, my little acronym for how to manage coronary disease is that everybody needs to be saved. It's not a religious proclamation. The S is for statin. The A is for antiplatelet drugs. The V is for vegan, whole food, plant-based diet. E is for exercise. And D is now for de-stressing. And I hope that we all keep paying attention to it. The moment there was a Takotsubo, cardiomyopathy, we should have clicked in our brains that the stress level really affects the heart, but it's not just the muscle, it's development of plaque. And if I can say one more thing, I'm hoping everyone within the sound of my voice, I see how many people, 39%. I want you to take a look at something that I still haven't figured out because I've learned about it in the last couple of weeks. A nice way to say this, so I'm just going to say it. There's one company out there that is popularizing the idea of meat with a side of cortisol. Have you heard about this? So
No.
apparently it's been known to a lot of people, but not me, that when you, I'm trying to find a nice way to say this, prepare an animal for market, okay, that they can see what's about to happen to them, and they are actually under a massive amount of stress. Dopamine, catecholamines, and cortisol all come out into the bloodstream and go into the meat. And you would think, I would think, when I first said this cannot be true. Gastric acidity, portal blood flow, first pass through the liver, all of it's going to be gone. Apparently, that's not true. And there's a growing literature about human stress, anxiety, depression, and behavior that goes along with it. And I had heard these little things like, oh, when I went vegan, my road rage went away and my domestic life got better. But, you know, I didn't know what that meant. Well, apparently there's more science to it. So far, what I've been able to find is jails where they actually separated vegan versus non-vegan jailed with one vendor. And he got all the gangs and the shivs and the racial violence to disappear, whereas they kept up in the ones that were eating meat, okay? Then a very unfortunate Yukon Husky study showed that there was psychological and physical partner violence that was dramatically reduced if the undergraduates were plant-based, and the aggressive behavior was in the meat eaters. And this data is just getting stronger and stronger, and it's apparently real, and we need to take that into account. So for the last couple of weeks, I've been talking to my patients who have not been plant-based, that this thing about stress and having catecholamines go in and raise your blood pressure, we thought it was all, plants are good for you, number one. It has got, potassium instead of sodium. It's changed your microbiome so that you're not getting the vascular response to bad bacteria in your GI tract. But no, it turns out it's hormonal. People should not be eating stress hormones from the process of an animal.
Kim, I'm so glad you brought that up. I was just thinking back to that old, it's an older now documentary called Food Inc., but it goes through the food industry, but it actually shows the animals, and you can see like their heart rates go up and all the things that happen before this occurs. The other thing I want to throw in, Andrew, is I think the benefits of weight loss, we don't always think about either. But I will tell you, one of my favorite jobs I've ever had, when I was a resident, I worked in our physician-assisted weight loss program, and it was a very low-calorie diet. But the things I learned there was within the first week, we cut insulin levels in half. We cut them in half on day one. And by the end of 2 weeks, people who ate less calories had way less need for insulin, but we cut everybody's blood pressure medicines back. And that's the only time in my life that I routinely did that until GLP-1s came out. And now everybody's taking these GLP-1 receptor agonists. You guys have probably heard about them, Ozempic and Mounjaro. And I'm cutting back blood pressure medicine so much more than I ever did before. And so it's, I think, again, just a good reminder, because, our populations are not successful at meaningful weight loss. Even in cardiac rehab, the majority of people don't lose any significant weight. And so when we start thinking about weight loss, we've talked a lot about positive body image over the years, and I think that's great. But when we need to lower our blood pressure, weight loss really can be associated with pretty profound reductions in lowering blood pressure.
I think that's a really important point, Alison, because I think first, with the advent of gastric bypass and all of its different forms, in addition to the GLPs, there's a whole variety of people coming forward now that, actually do achieve blood pressure control and diabetes reversal. Of course, which is more drastic, eating peas and carrots or having your internal organs rearranged. And then to Kim's point, and I always jokingly said that when you eat an animal product and you develop coronary disease, it's the way the animal is taking revenge on you. But you have to wonder, there may actually be some science behind this, which is really very interesting. So the other thing that I think we probably don't talk a lot about is us physicians, right? So many of us physicians, and then of course the entire care team, APPs and everybody else, it turns out we're not so good as patients and as lifestyle advocates for the most part. We know some people who exercise all the time. We know people who eat well but don't exercise. But it doesn't seem like a lot of us are portraying what we want our patients to do. And our education is missing. So I'm curious if you can comment, because I'm sure you guys are what I would call the enlightened few in your institutions, how you get other people to make these changes that are practicing side by side with you. And then what do you do when you see these disparaging remarks that you sometimes will get where, oh, that Alison or that Kim, they're crazy, even though the outcomes speak for themselves?
So I'm going to go second on that one, but I got a lot to say, but you could go for it.
Yeah, I think it's tricky. We all, kind of want our proverbial cake and eat it too. But I think that you have to tell people why. I got asked today, somebody was visiting our office and they were saying, well, Dr. Bailey's plant-based. And they're like, why are you plant-based? And I said, well, I really started reading the literature. I didn't get any nutrition information when I was in medical school. It's just something I was very interested in. And so did my own sort of education along the way, and really started believing that a plant-based diet was the most healthful. Now, I added dairy to that diet for many years, but in 2015, I decided, all right, I'm going to kick the dairy for a month and see if I can do it, because I recommend it to my patients and how I feel. And I never went back. I felt so much better when I removed dairy from my diet. I just never ate it again. And I think you can use your testimonial as a way to encourage your patients and say, I grew up in southeastern Kentucky, Kim's state now. We ate lots and lots of a sort of Southern diet. I thought I hated vegetables growing up, but it was really, I didn't like the way the vegetables were prepared, sort of that Southern style. And so if my taste buds can change, yours can too. It's a gradual thing generally, and it takes some time. And then, I share some of the things that I've seen, not only in myself, but with my patients, with my colleagues. And so we may be talking about, somebody who has really resistant cholesterol to treat. A sort of a traditional low-calorie, low-fat diet will only lower cholesterol about 5% on average in most people, but a plant-based diet can lower it up to 50%. It kind of depends on your genetics and what you choose to use. And that's not using vegan junk food, but that's using whole food plant-based nutrition. And I think that for those of you that are listening, you can see me, Andrew, and Kim have all used those words. Whole food diet, not a vegan diet, because vegan diet by itself is not necessarily healthy, and it can contain lots of high fat products to mimic that same flavor and taste of traditional American food. So I think sharing your wins, sharing ways that you implement this program, and then being excited about it, I think that speaks wonders.
All right, Kim, the floor is yours.
Indeed. So first of all, I resemble that remark. It was 21 years ago at the ACC that I went to the cholesterol medicine booth that was doing cholesterol, and I'd done it every other year or so, and it's usually had an LDL around 105, 110. And there's this thing that not everybody knows about of getting to a certain age where your LDL takes off. And so and I got to that age. So it turns out that eating that American Heart Association diet from back then, before we changed the guidelines, chicken, fish, no skin, not fried, was a very atherogenic diet. And it ended up with an LDL of 170. I didn't get the 50%, Dr. Bailey. I got from 170 down to 90. That was pretty close. And so been doing, plant-based nutrition, been doing it ever since. And but to get back to your what we really try to tell each other, the reason I wanted to go second is that I'm still a little sad about a publication that we had that talked specifically about physician nutrition. We did a study at Rush before I left, Loyola and Rush together, 274 physicians. This was, 2 years after the publication of the 2019 prevention guidelines that said, if you look at, section 3.1 of those guidelines, it said you basically have to be a whole food plant-based diet person to have your best outcome. I know the guideline had fish swim into it. And I took a lot of flack from a lot of people over that, rightly so. Now that we have the plastic thing from last month in New England Journal of Medicine, no one should be eating fish. But the real issue was that, AHA was very insistent because they are a stroke organization. And Predimed did show a reduction in stroke, not heart attack, not cardiac death, and not overall mortality if you ate fish instead of red meat. Okay, fine. But I figured that guideline would actually affect people. I should have known. So people weren't doing home blood pressures. People were not going to eat based on the next guideline I was involved in. And so it turns out that one person out of 274 was doing a whole food plant-based diet. And another 10 were doing somewhat of a Mediterranean diet. So 11 out of 274. And I was okay with it until I saw it in publication, and you see that graph, and it's just depressing because I know if you're not grabbing the physicians, we're not getting their families, we're not getting their patients. We are the people that they're coming to, even though we have all this data saying we don't get nutrition education, they're still asking us for advice, and we're telling them the wrong thing. Physicians are eating, and usually when I show that slide, I also show the slide of a preventive cardiology meeting. I won't say who and I won't say where they're feeding the doctors bacon, sausage, and eggs for breakfast. And so we've got to change from the inside. But we can do it. We just have to get that education out there. And that's why I appreciate you two very much, with the nutrition work group, all the stuff you're doing, the programs you're doing, Axel, all the opportunities we can to get in front of cardiologists who will then bring everyone else along.
Yeah, no, these are really good points. Oh, I'm sorry. Go ahead, Alison.
No, I was just going to throw in, Andrew, and I think our guidelines are more similar now for nutrition than they've ever been, which I think is also great for anybody who may be wondering. I saw the chronic kidney disease guidelines were just updated, and it said a plant-based diet could prevent chronic kidney disease, prevent development or progression of chronic kidney disease. So I thought that was fabulous. And, they're all more focused on sort of whole diet composition versus these individual macronutrients, which I think it makes it better for our patients. Because most of our patients, as you guys know, have multiple problems, not just heart disease, kidney disease, cancer, all the things that go along with an unhealthy diet.
No, really great points. And you guys probably remember that Steve DeVries, the guy behind the Gaples Institute, and I and a bunch of us in our nutrition work group published a paper of about 1,000 cardiologists we surveyed. And it turns out roughly 90% of us know little to nothing about nutrition. And most of us eat in the range of 1 to 2 fruits a day at the most. So I think we have a lot of work to do. And I think, being these beacons of light, if you will, in your institution is really powerful. And for me, doing this for 12, 13, 14 years now, watching people first look at me with contempt and now following my exact plan has been enlightening. But we still have a lot of work to do. And even at ACC, at AHA, at all these professional society meetings, some of the foods that are available, I mean, when we were down in New Orleans, was just mind-blowing. And we really need to fix that. And, I think the other thing that we often forget is, the AHA president had a heart attack on stage, right, in front of the entire meeting. And yet this was a golden opportunity to say, watch me make these changes. I'm going to get better. And we never took him up on that. So I think we have a lot of work to do. And I think, the medical training that we receive, with the exception of maybe burn nutrition, I got very little nutrition, and now it's starting to change. And I know, Kim, you're at the medical school there, and I'm sure you're probably pushing for this, but I'm curious, and Alison, you've had residents and trainees for eons, and as have I. If somebody trains with us, they always leave with a good, firm nutrition understanding. But what's going on if you're able to provide in the medical schools, and how is it changing, if at all?
So I'm going to tell you that that's another one of my aspirational targets, along with hospital food. I did make the foray into it already. The curriculum is kind of set, and you've got to, apply, and you got to come up with what it is that you would like to do. I did wiggle my way into the second year pathophysiology course after reviewing the nutrition section, which was a couple hours of lecture. it was all biochemistry. It was great. I actually learned a lot. It had nothing to do with human health and all of the cardiovascular stuff. So they were all shocked when I came in and talked about how, forget about intimate partner violence and road rage. Talk about hypertension, hyperlipidemia, obesity, diabetes, heart attack, stroke, as all the list of things that you could improve, including that kidney disease. I'm so glad to hear that the guidelines changed, because the National Kidney Foundation came out like 2 years ago saying, please put all your kidney disease patients, that animal protein is toxic, causes acidosis, acid load, that the kidneys can't handle, and all you need to do is improve them by putting them on plant-based nutrition. And the number of places out of Cal Irvine and University of Louisville that actually were doing this, I'm just not seeing them. So we've got to get the nutrition education out there. And without it, our patients will continue to suffer.
No, agreed. So we're going to use the last couple of minutes to answer some of our audience questions. And if you do have some, please type them into the chat. There was one question that came in about some of these masked hypertension things that you were talking about, Kim. So it says, if the office blood pressure is 30 points greater than the home blood pressure, and you thus see that people have a stress response, which is really accurate, should we do a 24-hour monitor to get a sense of the overall picture?
So I would say that our intent was to do home blood pressure monitoring. There is random monitoring versus ambulatory 24-hour, which not everybody has access to, because we were having trouble with insurance paying for it. I think it's a little bit more liberal now, but ultimately that's kind of like an event. You do do a monitor and then you send it back. That's not really what I want. I want the person, before they take their pills every morning, to actually take their blood pressure, measure it, and then bring it back, bring me sheets and seats, and make sure that they're controlled. And so, yes, the mass hypertension is the opposite of what they wrote. It was where the blood pressure is higher at home than it is. But knowing that people have office hypertension or mass hypertension will help you with the management, obviously.
No, a really great point. There's even some amazing things that just got FDA approval that are like Holter monitors for blood pressure that are cuffless that are coming out that will really change the way we practice. I'm really excited to see those. Another question we got was about fish. So obviously, besides the PCBs, dioxins, heavy metals, organophosphates, microplastics, and nuclear fallout, people want to know why fish might not be healthy. So Kim, maybe you could share some of that, or Alison, if you have some.
Well, I would just say, just please, put in your search engine, March 7th, New England Journal of Medicine, and then look up the whole idea of microplastics. And it's not that plastics aren't everywhere. They are. They're in the tap water. They are in plants. But the amount, the question is, how concentrated is it? And apparently it's concentrated in seafood, because we have polluted this planet to the point where that's what they have to eat. And so when you eat them, you're eating it. And so there are very few things in cardiology that have a 4.53 hazard ratio. And that's what it was like if your carotid endarterectomy specimen went to the lab and had nanoplastics or microplastics in it versus if it didn't. And that was future heart attack, stroke, and death. So this is a very serious thing. It's a game changer. Anyone who was saying Mediterranean diet really needs to think about it, because the fish are not the same fish that we had 30 years ago.
No, a really good point. And let me just interrupt real quick, Alison. So when I saw the carotid study, I wondered if it was the microplastics, or is the microplastic amount in the carotid simply a barometer of poor nutrition choices? Interesting way to think about it, I guess. But Alison, go ahead.
Yeah. No, and I was just going to parlay off sort of what Kim said, but the microplastics can be found in every water stream in the world. So even the most remote places, they're seeing microparticles or microplastics. So fish from, these open streams, it's not saving us from that.
Yeah. Now, I think the statistic I heard recently is most of us are eating in the range of a credit card's worth of plastic every year, which sounds really appetizing.
Yeah.
All right. So then there was another question here about sleep. I think I mentioned briefly about 7 to 10 hours. Just to answer this, and then I'm curious what Kim and Alison have to say. But if you look at lots of the research studies with sleep and sleep quality, they kind of have been a little bit all over the map. But if you try to put them all together, usually 7 to 10 hours of uninterrupted sleep at night is what's been associated with the least amount of heart disease. And it's not if you get 9 hours and 58 minutes or 10 minutes and 10 hours and 1 minute or whatever. There was a study I talked about in one of my talks recently, like if you went to bed at 10 o'clock, you were much better off than if you went to bed at 11 or at 9. Some of these things are hard to fully generalize to the population, but I'm curious, do you guys talk about a specific number with your patients, and what do you recommend to improve sleep quality?
I don't talk about a specific number because I think it changes depending on what's going on with us. There are nights if I'm having some pain from an orthopedic injury, I don't sleep as well, and that's for sure. And I can tell the next day I may have been in the bed more hours, but my sleep quality was much lower. And so I think that's true, especially with alcohol. We're recognizing more and more when people drink alcohol, their sleep quality is impaired. And so I think the quality of sleep, do you wake up feeling rested? Do you feel like you're ready to go for the day when you get out of bed? If not, your quality is probably not good. I think time is the easiest surrogate that we can look at. Or if I'm only in bed for 5 hours, I know I'm not going to feel as well as if I'm in bed for 7 hours. But I think it depends on how you feel the next day when you wake up.
So I was going to try to put it in the chat, but it seems like the chat is directed at everyone, or I'm sorry, at everyone in the meeting. That's the one I wanted. The 7 to 10 hours would bring up some concern based on the article that it just successfully uploaded into the chat. It's the idea is that if you look at all-cause mortality, anything more than 8 hours tends to increase. And what they're saying is that it's that 8 to 9 is 30% increase in mortality over 7 to 8. And less than 7, it goes up as well. So we really try to be intentional about letting people know that they need to be sleeping. But I can tell you that's, for the healthy people, for the unhealthy people, we get a lot of nocturia. That's a massive amount of it. And so they're getting interrupted sleep. And I don't know what to tell them. It's okay if every time you get interrupted, add another 15 minutes or something like that. And a lot of that nocturia improves dramatically when people go on a whole food plant-based diet.
A super good point. Are there other questions in the audience? Let's see. I'm sorry, go ahead.
Oh, sorry, Andrew. First of all, thank you all so much. This has been fantastic. I feel like I could sit here and listen to the three of you talk to each other all day. So thank you so much. There was a question earlier in the conversation. So as you all know, our audience and members of the Roundtable in general are comprised of health insurers, clinicians, cardiologists, community health workers, national nonprofits and associations. So one question I have for you all is somebody asked, do patients relate to the statistics that we all quote from the literature? And is there a way to communicate with them to help us engage them best?
I actually do this in my clinic because almost everything I'm saying, I have a slide on it with a trial. And so I will show them the Kaplan-Meier plot difference between statin users and statin stoppers. And I say, you choose your Kaplan-Meier plot. Which one do you want to be on? I think it's very effective, and people will make their own decision.
No, and I do the same thing. I tend to quote a lot of medical science. I do try to put it sort of in terms that I think my audience can understand. If I'm seeing another physician, I'll use a lot more stats versus if I'm seeing somebody who I don't perceive as understanding that. And I try to use things like 1 in 2 or 1 in 5, versus 50%, because I think people understand that a little bit better. But again, I think that we can't assume patients don't understand what we're telling them and not use great graphics like that, because it really is powerful to see those curves split really early.
No, I think stats are hard. I mean, they're hard for us, right? Most of us, I would tell you, stats are difficult after a certain level. Most of us understand some of the initial comparison tests, and then after that, it gets a little dicey. And I think helping patients understand how you've interpreted the literature with digestible stats are really powerful. So rather than showing them, the curves of blood pressure and all that, I mean, many people can't wrap their head around the top number versus the bottom number on blood pressure. But if you explain to them that if you take the top number and for every 20 points it goes above 120, their risk for dying doubles. And if where they are today, it's 8 times, I think people can resonate with that. And those are the stats that I try to focus on. But I think, if you get a sophisticated patient, they want the Kaplan-Meier curves. Tell me why I should do this. What's my risk reduction? Well, one of my patients asked me once the absolute risk reduction, right? Which of course is always much smaller. Pretty eye-opening. And then the other thing that I think stats are helpful for is when we're using our nutrition evidence. I love to share how beet juice, around 250 cc's or roughly a can's worth, has been shown to lower people's blood pressure as well or better than most pills, in the range of 7 to 10 points systolic with a sustained effect to the next day, right? Like saying it like that, most people can usually resonate with. Whereas if you give them this very arcane, and blah, 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 it's hard for people to get there. So I think it's all about how it's delivered. And then, of course, gauging how well people have taken it in is important. So I think I'm going to pass it back to Jenny, unless there's any final comments from Alison or Kim, because I think we are at time. And this was so very lovely to have you both and have these sort of fireside chats and hear what you're thinking and what you're seeing. And Jenny, the floor is yours.
Well, thank you again to Alison and Kim and Andrew for moderating. This has been fantastic. It gave me a lot of food for thought, no pun intended, as I, on the West Coast, get ready to grab my own lunch. But thank you all so much. We will share this recording out to everyone. It'll be on our LinkedIn, and we will also send an email out to everyone who registered. So thank you, thank you, thank you. I hope you all have a wonderful afternoon. And we'll see you for the next Fireside Chat in a few months. Bye, everyone. And you're getting kudos in the chat box. So just make sure the speakers see the chat box. You're getting lovely kudos.
Thanks so much.
Thank you.
Really a pleasure. All right. Take care.
Bye.
Bye, everyone.
Bye.